Today's lesson is on minimizing radiation dose to patients. Exposures of patients to medical X-rays is commanding increasing attention in our society for two reasons. First, the frequency of X-ray examinations is increasing amongst all age groups at a rate, they say, of approximately 20% per year in the United States, and is most likely similar here in Qatar. This indicates that physicians are relying more and more on X-ray diagnosis to assist them in patient care, even taking into account newer imaging modalities. And this is to be expected since X-ray diagnosis is considered much more accurate today than it has been in the past. The second reason that exposure to ionizing radiation has gained increased attention is the concern amongst public health officials and radiation scientists of the risks associated with medical X-ray exposure, such as acute effects and stochastic effects. The objectives, therefore, will be to discuss the factors that contribute to unnecessary patient dose, to describe the safety guidelines used for prescribing X-ray exams, and to discuss patient dose, intensity, protective measures that we use to reduce patient radiation exposure, and any recommendations. And also, we will be looking at the purpose and the use of dose area product and diagnostic reference levels. So as mentioned in prior lessons, we have to remember that the responsibility for ordering a radiological exam lies with the referring physician. In making this decision, the physician must determine whether the benefit to the patient in terms of medical information gained is sufficiently justified. Some radiographic exams are performed in the absence of definite medical indications, and this practice unnecessarily exposes the patient to radiation because there is virtually no benefit to the patient in terms of useful information gained from the procedure. Examples of this are non-essential exams described in this figure from the radiation protection textbook. Let's look at number 1 in this figure as an example. Here it says that a chest X-ray examination on scheduled admission to the hospital is unnecessary. The examination should not be performed without clinical indications of chest disease. And then another one here, a chest X-ray exam as part of pre-employment or a pre-employment physical. There is very little information about previous illness or injury gained from taking this chest X-ray, so it's unnecessary. If you look at number 6, it says that whole body multi-slice spiral CTs are often used for screening purposes, and patients may elect or choose to undergo this type of procedure for screening without an order from a referring physician, and this is simply unnecessary. As you know, CT doses are a lot higher than general X-ray, and for this reason, CT screening should not be done, unless, of course, there is a valid reason to do so. Unnecessary radiation exposure of patients can be significantly reduced by ensuring that all examinations are clinically justified. This can be done by adhering as much as possible to certain basic recommendations, and these are the recommendations presented in this slide. I would say that for all or most of you, this is basic common knowledge when it comes to taking X-rays of a patient. We all know that we cannot take an X-ray without a prescription from a doctor. There has to be a requisition in your hand, or you have to review the requisition on the computer before you can even begin to take an X-ray on a patient. There has to be a history associated with the patient. So that means that an X-ray exam would not be performed unless there was a prior clinical examination done on the patient by the physician, and that's the physician that's ordering the exam. Radiological screening must not be performed, of course, unless it has been proven that the benefit to the individual will outweigh the risks of the procedure. When you are taking an X-ray in the department, you are always looking in the system, in the PACS, to determine whether there were any previous X-ray images, especially if it's a follow-up X-ray. If the prior images relate to what you're currently doing, then it is of vital importance to check that first. Also, examinations done at other hospitals should be checked as well to determine whether the exam is necessary at all. Perhaps the patient transferred from, let's say, a Doha clinic to Hamad Hospital, and they already have images of the chest, and the chest X-ray was maybe taken just a few hours prior, Why would it be necessary to repeat it? What would possibly have changed in the last couple of hours? That would have to be assessed first before even considering taking another examination. It is good practice for the technologist to always check any relevant images or reports that accompany the patient. And these reports and these images should also be reviewed by the consulting physician as well as the radiologist. When the physician is ordering an X-ray procedure or examination, they have to be very careful to specify correctly the clinical indications and the information required. I'm sure you've come across in the clinical where a patient is scheduled for an examination and perhaps they've specified that it's the left ankle they need, when really the patient has pain or an injury in the right ankle. So this, of course, if they specify correctly, then we would avoid repeats and hence avoid any kind of unnecessary exposure to the patient. Also, we should always be trying to reduce or minimize the amount of x-rays we take, within reason, of course. Sometimes that's out of our control and there's nothing we can do about it, but and the doctor requests a certain amount of x-ray projections, and that's what you have to do. But when you can minimize the exposures, considering children, for example, if you can get away with 1 versus 2, then that's what you should be doing. Before performing X-ray examinations on females of childbearing age, don't forget that you have to ask the patient when their last menstrual period was, or whether they are married, or whether there's any possibility that they could be pregnant, because that could reduce the potential dose to the fetus if the patient was pregnant. If a radiograph contains the required information, repeat procedures must not be done simply because the radiograph is not the best. If you can see what you need to see, then and it's diagnostically acceptable, then put it through to the PACS or to the radiologist to report. The key points to remember when carrying out X-ray examinations, and this is based on Canada's Safety Code 35, is do not perform exams if they've not been prescribed by a doctor. Always keep those exposures as low as reasonably achievable and follow the recommendations, especially when it comes to pregnant women, because you don't want to cause unnecessary dose to the fetus. Always collimate the X-ray beam and limit the collimation field to the size of the image receptor or smaller if that's possible. Use automatic exposure controls when it's possible. And when you are using it, make sure you are selecting the right sensor. Always use gonad shields when practical. So you use those flat gonadal shields on the patient to protect their gonads, but you're not going to be using that if you suspect that it may interfere with the area you want to see. Use shielding only when appropriate. Focal spot to skin distance should be as large as possible, considering the technique, because the smaller it is, the more dose you are giving your patient. Radiological exams of infants and children should only be performed with techniques and loading factors that are modified for their specific size and their age. And for very young children, make sure that you use special devices to restrict their movement. Because if you have an immobilization device like the Pigostat, for example, there is less chance of you having to repeat that chest X-ray. This is a continuation of what is found in the Safety Code 35. And here it says that you have to ensure that you have the edges of the X-ray beam visible on the X-ray image. You have to ensure that you use anti-scatter grids or an air gap technique between the patient and the image receptor, because you know when you have that air gap technique, it improves the contrast. It acts like a grid, which could result in a reduced exposure. The use of the highest X-ray tube voltage should always be implemented as well, because we know that the higher the kV is, the lower the MAS we need, and MAS directly influences the amount of X-ray photons reaching the patient. Also, it is good to employ the use of automatic exposure control, because if we use it the way it has been designed to be used, we can keep the irradiations and repeats to a minimum. Also, we should be evaluating our initial image when we're starting a series of images to make sure that the first one is good and that we don't continue on and find out later that we took a bunch of images where the exposure was too high or too low for that matter, and we have to repeat. The safety code recommendations for fluoro and angio procedures, similar to that found in the radiation safety textbook, basically states that you should only be doing these examinations when you cannot obtain a similar result within a general X-ray. Also, people working in these areas should be trained, and they need to know what they're doing because the exposures are higher than usual. Automatic brightness control, we have to be careful when it comes to this. It has to be monitored as it directly affects the tube current and the voltage, which obviously has a direct relationship to the patient's entrance skin dose. When we are doing cerebral angiography, we have to look at the technique and consider the dose that we are providing to the patient's eyes and thyroid, and we have to determine whether it's possible at all to give the patient some shielding. Apply shielding when it is possible. Try to reduce the dose to the patient by keeping the irradiation time to a minimum. Use increased tube filtration if this is possible, and use a lower time frequency in pulsed fluoroscopy. Keep the X-ray tube further away and the image receptor as close as possible to reduce exposure to the patient. With small patients, the removal of the grid also reduces patient dose. Image magnification increases dose and should only be used when necessary or when the doctor asks you to magnify the image. When you know that you will be doing a long fluoro procedure over an extended period of time, let's say a half an hour or more, make sure to reposition the tube when possible. We do not want to subject the same area of the skin to the X-ray beam for long periods of time because, as you know, the skin is quite sensitive and we want to avoid the risk of erythema. Always use pulsed fluoro when possible because this reduces the patient dose by as much as 90% when you compare this to non-pulsed fluoro. Here's an example of how magnification using an image intensifier can affect the patient dose. In the first image you see in figure 1, the choice of technique was 75 kV and 2.4 mA, which resulted in an entrance skin dose of about 35 milligray per minute. But in image J, or figure J, which is beside the first one, when the image was magnified by a factor of 1.5, the system increased the X-ray tube voltage to 85 kV and used a tube current of 2.7. So just looking at the difference between the two, when the image was magnified, automatically the kV jumped by 10 kilovolts from 75 to 85, and there was a slight increase in the milliamps as well. So slowly the system will adjust for the kilovolts, and we know the higher the kV, the lower the MAS normally is in general radiography. But here, with an increase in kV to compensate for magnification, there's also a slight increase in the milliamps and a gradual increase in the dose to the patient. So how about mammography and patient dose? Well, we know mammography is images of the breast used to detect breast abnormalities like cysts, benign and malignant tumors and lumps. Screening mammography is done when there is no known symptoms, and it is normally for early detection of breast cancers or when breast cancer runs in the family and you just want to ensure that it hasn't affected you in some way. So routinely it's performed at the age of 40 to 49, and it could be done either once a year or twice a year. It is something that the patient can decide themselves to undergo, or it can be a referral from a doctor. There is lots of controversy at the moment regarding the age recommendation for screening, as some organizations, radiological societies, believe that screening should only be performed after the age of 50, and that 40 to 49 is still quite young. Breast tissue, especially in young women, as you know, is very sensitive or more sensitive to the effects of radiation than would be in an older person. There are a few studies, not very many, that have indicated that screening for breast cancer using mammography may cause as many cancers as it finds. Dose reduction in mammography can be achieved by limiting the number of projections taken and trying to keep the dose as low as possible. And regular QC should be performed on all of the equipment, and preventative maintenance tests should be done to ensure that the equipment is working correctly at all times and evaluated so that high doses do not occur. For the most part, digital mammography has replaced film-based mammography to provide optimal images at low doses. Glandular tissue dose should not be more than 2 to 3 milligray per view.